Welcome to Future Conversations. I am Mira Sivasodi, Professor of Practice, Digital Media and Communication, and our topic today is Beyond Forgetfulness, Rethinking Dementia Care in Malaysia and the World. Dementia is often dismissed as simple forgetfulness or seen as an inevitable part of aging. But the reality is far more complex and far more urgent. The number of older adults suffering from dementia in Malaysia is expected to nearly triple over the next 30 years. In this episode, we explore what dementia really looks like in Malaysia, from clinical care, caregiving to culture, prevention, and the future of brain health, while also placing our experiences within a global context. Joining us today, Professor Dr. Tan Maupin, Head of the Division of Geriatric Medicine at the Department of Medicine, Universiti Malaya, also President of the Dementia Association of Malaysia. Jenny Lim, the Resource and Training Manager of the Alzheimer's Disease Foundation Malaysia. Dinesh Sangarran Ramachandran, who is the lecturer at the School of Pharmacy, Monash University, Malaysia. Dinesh is also an EXCO member at the Alzheimer's Disease Foundation Malaysia. And Siti Maisarah Mattap, the lecturer at the Cheah School of Medicine and Health Sciences, Monash University, Malaysia. Welcome all of you to Future Conversations. I'm going to start with Professor Tan. Do we know how many people are living with dementia in Malaysia?
Well, we will soon have an updated figure because the Ministry of Health has completed the National Health and Morbidity Survey last year. They had one in 2018 where they thought 8.5% of people aged 60 years and over have dementia, and that was then based on that estimated 200,000. That was 2018. So the updated one that will be coming out soon will be published based on the same survey, but if we actually extrapolated it, there will be more than 300,000 now, based on just the population and 8.5%.
And how are we coming up with these progressions? Because most people don't come and get diagnosed. Do we know exactly, or is this just an average? We're taking from other countries perhaps who have gone through this.
Okay, so it's not quite so bad as we're just modeling, but it's basically a survey where we actually it's a representative survey, so they actually select, I think, 3,000 individuals aged 60 years and over throughout the country, and they actually use a questionnaire, so a test, a memory test, but a simple one, a short one, and based on that, the cutoff will allow us to estimate it. And the previous estimate of 8.5% was quite congruent with the estimates we got from Singapore and Thailand, which suggests that actually we're nearly there. We're actually there. But of course, if we want really, really accurate diagnosis where you have scans and blood tests and a doctor confirmed diagnosis, we are not there yet. Overall, it's getting harder and harder to do those sort of things. Previously, these things used to be done, but internationally, I don't think in the last decade anyone has actually done that kind of very detailed surveys. It's very difficult to do.
What are some of your concerns for Malaysia?
Whoa, basically, we are totally overwhelmed. There are so many people living out there with dementia, and they are totally underserved. Awareness aside, families are really struggling because we've lost the extended family structures. We are now an aging population, so there are fewer people in the productive age groups. So there's a caregiver crisis, very, very stressed middle generation, sandwich generations, totally overstretched services, and a health service that really does not know how to deal with people living with dementia. So many people living with dementia go in and out of our hospitals and our outpatient services every day without people knowing they actually have dementia.
Okay. Jenny, what does dementia look like in a Malaysian home? I mean, you deal with people on the ground, you are an NGO, you're a non-government organization. What does that look like?
Well, from ADFM perspective, we receive many calls that come to us, and most of the time, by the time they reach us, they are already at a stage whereby they are so struggled that they don't know what to do. A lot of crying over the phone, looking for answers where to start. Yeah. Majority of them do not know what is dementia even. It is describing the problems that they have at home, what they are going through. And also, the stigma is there. They don't want people to know that, the dad or the mom is going through this phase of anger, frustration, struggles. And majority of time is also the financials. They are very burdened. Um, Many of these families are small nowadays, so meaning that they are not able to get extended help. So we have a guy that called up and say that, should I give up my job? Then my question back to him was, if you were to give up your job, where will your income come from? Right? So it's a very mixed feeling over the phone. And therefore, from ADFM, what we could do is to provide them training, provide them education, counseling over the phone. We do invite them to come over as well. Yeah. So some of them who are in between, we invite them to get a diagnosis done first, and then perhaps to send their loved one to our daycare. So our daycare is subsidized. So we said not to worry. If you can't pay, it's okay. Because being an NGO, we do get donation from the public.
Yeah.
So there are people who come and don't pay like 6 months. It's fine.
Okay.
But it's not that they don't want to pay. It's they can't.
I I don't want to sound harsh, but it sounds like a fractured system at the moment. We know we are going to be an aging population with time. I think 2030, it was 2035 in before we estimated we would be an aging population, but we're there. We are unable to already deal with it, right? So how, I mean, Siti, you, Sarah, you work with in the areas, or you've done research when it comes to stigma, culture.
Yeah.
You want to tell us a little bit more about that?
About stigma and
Yeah.
culture and things. So, based on my communication with the community, I can see that culture and religion plays a big, actually a big strength when we are talking about dementia care, because family, they have a deep responsibility to take care of to look after, to take care of their loved one at home. But at the same time, this gives the person with dementia love, familiarity, and then dignity as they are within their ecosystem without being removed to institution. However, that sense of duty can be an overwhelming for the caregiver or the care partner, we say, as this role can make them feel that, like Jenny mentioned just now, they can share, but not all will share. From my experience, some feel that as if they are less of a care partner if they show their vulnerability, and as if that they are guilty or they are doing something wrong if they show their weakness. And in our culture too, that decision making, I think some can agree too, some families, decision making for our older adults, it is a shared responsibility within the family. The spouses, the children will come together. It is supportive because they collectively make a decision, but that can make it hard for navigating the care, making it more complex. And for religion aspect, I can see that most Malaysians are quite religious, and especially when they are in the older adult stage, they wanted to be more near to worship more. But the facility that we have, the religious facilities and the worship spaces are not dementia friendly. And most of the care partners, they are decision makers sometimes. So they will feel like, oh, we should remove them so that they don't feel embarrassed, or they don't feel, so because of fear too, if they allow the person with dementia, the older adults, to go and still doing their normal routine, worshipping at the worship place. So yeah, there are strengths, but also there comes of problems with that too, within the culture and the religion.
So when you talk about this whole idea of dementia, do you think it's awareness that's lacking, Prof. Tan?
Yeah, so it's less so now because we have more and more people coming forward themselves early on worrying about their memory, and that's very much welcome, but we don't have the system to receive those patients. But the main issue we've been having for many years is people just assuming that memory loss is very much part of old age, and that is not isolated to the general public. We even have doctors who think that, because a chapter on dementia in our medical textbooks that they read as medical students was so tiny. And it was assumed that dementia is a disease that has no cure, and it's a disease of exclusion. So very few people actually had any formal teaching on dementia, and those are now our senior doctors. And then they are guiding their juniors what to do. So we tried teaching them in second year medical school. That a lot of the knowledge had dwindled by fifth year when we tested them again, and so definitely when they go out there, whatever knowledge they have has been rubbed out, because their role models are, I mean, for want of a better word, ageist. And they just don't want to deal with people living with dementia.
Dinesh, a lot of your work is in the area of awareness. You want to share with us what you actually work on in terms of research?
So echoing to what Prof. Marvin said, my initial idea was not to have the classroom teaching just end at that week, because we teach dementia for one whole week and we do not want the students, okay, close textbook, finish, next topic. So my intention was not to end there, and that is why we have come up with new interventions or new project which is working very closely with the younger population, especially young students in Malaysia, to come up with awareness intervention which connects very closely to the people with dementia. So that has been going very successfully, where we have 3 groups who are come up with new interventions, very much in digital health, campaign awareness, and they have collaborated with many NGOs and also many care homes, where the exposure is very much seen among the aging population and also people with dementia. So ultimately, the aim is to bridge the communication and relationship between the younger population and people with dementia, and of course the caregivers, so that they do not feel alone in this journey of their life. Yeah.
And you're from the School of Pharmacy, not really in the School of Medicine.
Yes.
So, but how are students taking to this though? Because in our younger age, we don't think of ourselves aging. I never thought in my 20s, I didn't even think about what I would look like at the age of 50, right? So how do you get them involved?
So it's more of the motivation that we need to give them, especially connecting it to our own family members, looking at the risk of what is going to happen if you were to have your own family members living with dementia. So giving them that sort of interest and also that motivation gives them that encouragement to move forward. And of course, to also with many NGOs, where if you see a lot of NGOs in the field of dementia, most of them are in the aging population. The volunteers are already in the aging population. We have a lack of young volunteers in the NGOs working towards this dementia care. So just giving them the exposure, we need you guys to be part of this, to be carrying forward these initiatives. So that sort of initiatives we are trying to cultivate among our students here. And from the School of Pharmacy, I am also giving a lot of importance on the medication management profile, because that is a big topic. I think Prof. Marpin will also agree that the whole journey of managing the medications for people with dementia, with of course the other conditions, is crucial.
Yeah. Wow.
Yeah,
Because
there's actually the thing is, we always assume that the older person needs to teach a younger person, but what we find is these undergraduates, they have grandparents, and their grandparents may have dementia.
Yeah,
Many of them
agree.
do have grandparents with dementia. So we are actually mobilizing the youth now to try and educate the population, because they don't come with preconceived biases. So we formed this alongside what the young dementia group that Monash has developed. We've now also have a student chapter
under DAMAI.
of the Dementia Association of Malaysia,
Right.
DAMAI. Yeah. So DAMAI student chapter, wow, it's grown so fast. The last I heard, they had over 100 members, and they are actually going forward to try and plan strategies to hopefully have a student group in every medical, not just medical school, but any college that actually has a healthcare course. So nursing, pharmacy, allied health, as well as medicine, to try and turn the problem on the head and say, no, you can't. It'll take a long time if we're going to do it the way we currently do it, where the seniors teach the younger ones. Let's turn it around, flip it.
Okay. But why don't you just open it up to everyone who's young in the country? It doesn't just have to be students in educational institutions, right?
We are taking one step at a time. So I think the next step is to involve a lot of other younger generations, maybe even school. That is the next step that we are trying to build upon, to have that awareness among the kids in the school. So that is one step that you're working towards.
Okay. It's a plan.
It's a plan.
I'm happy you have a plan.
Well, actually, because we have a dementia care center in Segambut that's funded by Genting, and every year a kindergarten brings their children to the dementia
Very
center,
interesting.
and they have a great time. So we had it the first time 2 years ago, and last year they asked to come back. So it's become an annual event, because what the feedback we had from the parents and the teachers is that the children was so much more responsible and mature just with that brief exposure, and the effect, the positive effect it had on the older adults in our center was amazing. They felt so loved because the children were there.
Yeah. I mean, I've always had a dream where
Exactly.
I would have a dementia care center and a preschool next to it, so they could have
interesting.
daily interactions and help each other out. Right?
And I've also seen a lot of excitement, like what Prof. Mopin said, when there was involvement of youth and younger generations when it's towards the people with dementia, even aging population. They are very excited to receive them for whatever awareness work or intervention that they are doing. So I think the effect is so rippled in a way that it's reaching out to many people outside there. Yeah, so that is such a good initiative that we have come upon.
Okay. Jenny, you've had challenges. You're trying to have educate caregivers and provide training sessions for them. However, you have mentioned that people don't come forward. People are not willing to invest in these training sessions. You want to share more with us. And then what could be a possible solution to bring more people to these sessions? Because it's free, some of it, right? And yet you are unable to get the right people in.
Right. When I mentioned that, it doesn't really apply to all the courses. We actually have got 3 different languages. The English one normally is full, Mandarin not so full, and Malay session, we can't get the numbers. So we are not sure as to why, but why we have different languages in our training is simply is multiracial, and we want to actually get those who are from the lower income group. Yeah, for them to understand more and also to learn the skill how to manage their loved one.
Yeah, because those who have the means have access to care, right? Sarah, can you relate to that? Like in terms of the different races and how they actually are open to this sort of training?
So what I can relate with is that maybe in rural. So in race, I'm not really sure to discuss on that, but in rural context, it's less care and less reachable of whatever that we have in the main city, like offered by ADFM, like Genting Care. So
Access
is one huge issue. Plus, when we talking about culture, it's when one caregiver, the main primary caregiver, is in the city, and then the persons with dementia or the older adults is in the rural area. it is really hard to navigate how do they come together as a family to bring them to get the appropriate support. Based on one case that I know is that person with dementia, the family members after 6 months, I met with them 3 times. The last 6 months, then I know they actually do have doctor diagnosis. Why? Because of managing the care, and then not only dementia care, but the financial, and then the other comorbidities they have, hypertension, diabetes, and chronic kidney disease. So that's one issue. But in terms of race, if you bring that back, I think equally the same in terms of awareness, I guess. And the differences will be, the disparity will be like the education level, and also the access, again, like where they live.
It's a totally family-centric view, because it people seem to have this mind block that just because there's no family members means a person can't access care, because you might the whole situation, the whole environment requires that the older adult can only access care if their adult children brings them. So there needs to be a sea change into enabling this older adult to access care themselves. It's not the children's fault that they can't get to the hospital. It's the hospital's fault that they organize appointments without finding out how the older person is going to get there. And we need to mobilize the community, get this person to access memory services as soon as they notice something's wrong, rather than going, I can't get there because no one's bringing me. So the only time they get there is when the ambulance turns up on the doorstep to take them to hospital. And that is really the most expensive way to manage dementia.
Is there a country that we could emulate or get ideas from?
Well, in many countries in this world now, there's just simply not enough young people. So older people go to the hospitals without the assistance of a younger relative. So there will be hospital transport services. So when you organize the transport, an appointment, how is this person going to get there? If they don't have anyone to take them, then there's a system where an ambulance will. And they're not the proper kind of blue light ambulances. It's
Transport.
more like a bus. A bus, a transport will pick them up and drop them back. So those are the systems that we need to consider. So when we fund healthcare, we are actually hemorrhaging resources when patients can't get to appointments because appointments are not attended. So that those kind of provisions need to be put in place.
Okay. It's often said dementia is not one disease. Dinesh, do you want to tell us more? Why does this misunderstanding matter when it comes to diagnosis and care?
Yep. So actually, I've seen even in the study that I've conducted, whenever I ask the care partner, all right, what type of dementia your loved one is experiencing, they'll look and say, is it Alzheimer's or is it vascular dementia? What is vascular dementia? So that kind of understanding is still lacking among the care partners or caregivers, because dementia is a general term. There is an umbrella term which has a lot of other things sparked, like Alzheimer's disease, vascular dementia, frontotemporal, Lewy body dementia. Vascular dementia is very related to cardiovascular risk, whereas Lewy body it has some kind of sensitivity towards certain antipsychotics. So I think the awareness is still lacking among the care partners and the caregivers of their loved ones. So all of this would result in mislabeling and misdiagnosis. They would have wrong medications being given to their loved ones, or even sometimes they would go to a pharmacy and say, oh, my mom is experiencing this, so just can you give me a medication? There'll be a lot of fragmented care, meaning not one doctor owning to the list of medications that their loved one is taking. So all of this is a work in progress, which we need to educate the community.
Jenny, what keeps you going every day?
What keeps me going?
Given it's such a complex ecosystem, which, as I said, is close to being, I can safely say it's fractured. I don't want to sound like a pessimist, but it is the case. And we'll come back to Prof. Tan to talk about the Dementia Action Plan, but what keeps you going every day, and how do you
Well,
keep the association going?
Well, I think the first thing is that from myself, I'm also a caregiver. My mom is 92 with dementia. My sister also has dementia. My grandson, ADHD. So a lot is happening in the family, and that makes me stronger. That the community needs us. There are so many types of disability around, but it's not only dementia alone that we are not prepared, but many other things that the country is not prepared. And look around at the economy. Where are we? We have more B40s and below, in our country, and they are not being supported adequately. Yeah, it keeps me going because I'm one of them.
What would you need from society to support the Alzheimer's Disease Foundation Malaysia?
We used to have a lot of donation coming in, and we could do more things, but donation is slow in coming in. And when there is a slowdown, we know that the economy is not good and people are struggling. So we have to go out to do more in order to function ADFM. Yeah.
Okay.
So we also get different stakeholders, not to burden them. So different stakeholders do different things. Yeah.
Prof. Tan, we have the Dementia Action Plan, which was launched October 2024. Have we gone very far? It's way
the truth
over
is
a
we
year.
might have gone a long way, but nobody knows, right?
Yeah.
Because the monitoring arm is not happening.
Right.
So this was, it took so long because it started in 2019 for 5 years for the plan just to be written. And if you read the plan, it's an amazing plan. It's brilliant. It's almost perfect. But that lies a problem. If you almost feel that there is no buy-in into the plan. They just want a plan that looks perfect. But if it almost needs to be imperfect because people need to know that they need to implement it. Yes, and they would have said, "Oh no, we couldn't have done this, we couldn't do that." But so I've been very much involved in the research arm at being a university, and when we looked at the plan, we actually felt quite positive because we've already achieved it because we felt we put in things that we could achieve. But could we tell anyone that we've achieved it? And could we find out what other people are doing? There's just no platform. So, and I suppose we were all looking for the government to provide this platform. But I understand the issues, but we shouldn't always just blame the government. Remember, this is a whole of society, whole of government approach. And really, we are all at fault. We are all responsible to make this happen. Don't just point fingers. So the frustration has brought about the formation of the Dementia Alliance of Malaysia, which is the idea is to bring together NGOs, all stakeholders, civil society, and also engage with the government side to see what is being done and how we can actually amplify whatever is being done in order to actually accelerate the efforts and make dementia care far more accessible. So that's the whole idea, and it is moving, but of course we can't find that many people interested in this area. Yeah, because it doesn't seem glamorous.
I was just going to say, do you
The
think
interest.
the aging is just not sexy enough?
Exactly. The interest is just not there. People think that, oh, it's a condition that we have to live once we get old.
Yeah.
Yeah, that's about it.
And then when we get there, we'll be like, oh,
Yeah.
this is what they meant.
Exactly.
And we all assume we're not going to get there and that we will be aging fine, right? And that's the other thing. We don't know what causes dementia. And I think that is another challenge. Or do we know now what causes dementia, Prof. Tan?
Well, actually, we
Yeah.
know so much more. So the Lancet Commission publishes this update on modifiable risk factors for dementia. And that's what we call the low-lying fruit, the biggest bang for buck, right? So we now know that 45% of risk factors in dementia are modifiable. And they've split this into early life, midlife, and late life. And a lot of the risk factors are actually concentrated in midlife. So even prevention itself really needs a lot of attention. But we now have a drug to cure dementia. We now have a very expensive drug that can actually be used to reduce, to wipe out the amyloid in your brain, which is what is found in the brains of people with dementia. And more, we are able to now reverse the memory changes. Previously, it was all very bleak because for 20 years, there was so much poured into dementia research and nothing. But so much is coming out now, and there's so many more new drugs in the pipeline. So while it's unaffordable to most people now, it will become affordable not in the near future. So and our country is nowhere near ready to deliver any of those stuff. So in order to treat, you need to diagnose. And you need to diagnose early, because you don't want to be treating them at late phases and arrest a disease where someone is very debilitated. You want to treat them early. So, and really there needs to be a lot more concerted effort in updating our services. We actually feel like we're all running backwards, right? Because it is like the train, we're moving forwards. We are moving forwards, but the issue is like going so much further away. So really much more concerted effort in dealing with this.
We're not moving fast enough. But what about diagnosis? That's another challenge, isn't it? Because you have scans, MRI scans, you have cerebrospinal kind of diagnosis. A lot of people are working on biomarkers. How certain is diagnosis?
Okay, we're there, but for Malaysia, it's expensive, and the gold standard test, we call it an amyloid PET scan, is not available.
Why?
We've been trying to bring it in, but because of the cost, the manufacturers feel afraid they will not be able to recoup the cost. And the China market is huge, so they're just mopping up all the world supply of the amyloid ligand, so we can't get hold of it. So we don't have amyloid PET scans in Malaysia. So we are able to deliver the blood tests. The blood test is actually sent to America for processing, but it is costly. So and given that the disease modification hasn't quite arrived, we only have a few people who will agree to even have the blood test, and the CSF test. There's still a reluctance to do a CFS test until I presume when the treatment arrives, and they might be willing to then have a lumbar puncture because it's invasive. So we have had a couple of people agree to it at last, but I think getting past the doctors is quite difficult because they're so used to not doing any of these things. Trying to develop a system that will deliver these things and to persuade the doctors to do it, it's already very hard.
Prof. Tan, we have GPs, we have a primary healthcare system which can be strengthened, definitely can be strengthened, but can the GPs play a role when it comes to diagnosing or supporting people living with dementia?
There's no choice. They have to play a role simply because of the volume of people involved now. And the GPs are the ones who are right next to these older people's homes. So we really need to train them up to do the screening. And then once they've detected someone with memory problems, to send them somewhere for the confirmatory diagnosis and the management plan. And unless they really need the disease modification, which is a monthly infusion of something very expensive, they can actually be then referred back for a shared care model. Or sometimes, if the GP is confident enough, they can manage them on their own. But so we are now trying to develop this model. So we are partnering with two GPs in the community in a private clinic to actually see whether shared care does work. So I actually visit the clinic on a Saturday morning to see the patients, and then but then for some investigations, and if they need disease modification, they're referred to tertiary care. So hopefully that will reduce the cost, because suddenly you don't have to have a big hospital to do all this. It's based and it's hopefully accessible to the older adults.
But that would be private, am I correct?
Private.
But what about clinic kesihatan? We have tons of them all over the country. Can they play a part as well?
They actually have been doing that program for a couple of years already, and there are 1,076 clinic kesihatan in West Malaysian and the other side, the East Malaysia side. So what happened is that some of the klinik kesihatan, they do have family medicine specialists and they are able to prescribe certain medication, not all, and further screening need to be done. Then it's then referred back to GH.
Okay. And I'm assuming, is that connection to care clear? Like, do people come forward for further treatment? And the reason I ask is because we find this happening with screening for cervical cancer as well. You know, we've got these HPV DNA screening tests, but connecting them to care is a problem because one is stigma, one is they're afraid of what to expect, you know, that kind of thing. And it takes a lot of hand-holding to get a patient from screening to care. So are we doing well in that area?
Well, we just had our Train the Trainer program, whereby KKM actually nominated 19 of FMS to ADFM to be trained. From that perspective is that those FMS will start a program on their own to support their patients. Yeah. So we hope that in time to come, more could be done.
Okay. Sarah, you work, or you're doing a pilot project in Vietnam. Let's talk about a different country. What have you found from your research in Vietnam?
So I was doing a work named Dementia Toolkit for Carers that is targeting Malaysia and Vietnam, trying to see the similarities and also differences, challenges and barriers in dementia care, especially supporting the caregiver. And at the end of that, we're trying to create an intervention, which is a tool to help the caregiver. And what we can see when I was there, tried to collect data and talking to the community in the rural of Vietnam, and we conduct the same study in Malaysia of Segamat. It's not a totally rural, it's semi-rural. We see that similar pattern, similar overburden of the caregiver when they are caregiving for their loved one. And the issue is still globally the same when you are talking about caregiving of person with dementia, their needs. And what we see is the difference is, even though their healthcare system is totally different than ours, there are some similarities here and there. We face the same challenges and we can try to use the same kind of solution but adapting it towards the suitability of the context. So what we have for Vietnam, that we proceed faster there, they need teaching, training for the caregiver. They are silent about, they don't tell about their struggle until we are really deep. And what we found that they say they need education, but they don't no time. Everyone is too busy caring for their loved one, making sure the family are all fed, going to work and so forth. So we make a very brief. We just pilot it. We try with a video kind of intervention, and we share it through the common platform they use. Here in Malaysia, we use WhatsApp, but there they use Zalo. So we disseminate it through Zalo, and then we also give them just a backup, a booklet, a printed booklet. And what we see is really promising, that they really need some kind of education so that they know how to handle their loved one. And we only focus during that time, because it's pilot, we only focus on meal time, because it is always often overlooked that mealtime, just give them some kind of food, doesn't matter what color, doesn't matter the nutritional value, because again, we need to keep it, they need to keep it within their means of financial. And it's a good promising study that we might continue later, which in Malaysia we'll try that later soon. Yeah.
Okay. What do you hope to do with the study to establish the toolkit?
To establish a support system that is easy for them to access, and then that's not taking too much time, and also using a medium that they are very well versed, familiar. Yeah.
Okay, let's talk about awareness in Malaysia, Dinesh. We spoke about it a little bit just now, but what platforms have you been doing to bring about awareness? And as Sarah said, there's so many platforms we can use, right? Not just the traditional platforms. Digital is powerful.
Yeah.
How do we use that better? And you're hoping to bring younger people to think about these things, right?
Yeah. So it is all about contextualizing towards the patient. people with dementia and not the diagnosis. So it is coming up with interventions on AI and digital health for something which would be contextualized for them. So though it is going to solve something, but sometimes AI and digital tech solutions will also widen the gap. We have to talk about how it's going to be accessed in rural as well as the urban population. So whenever we come up with something, we have to not design something for them, but with them. So where we have to take their perspective on what kind of solutions which are needed for them, not just say, okay, we have this digital tech solution, please use it. No, it's just not that. Something which will be easy and handy for them to use. And of course, when it comes to having them to operate it, we cannot be having many systems to log in, and all the fonts are available. It's too small for them to look into something which is friendly for them, and it is easy and simplified for them. Yeah.
Okay. So my other problem with digital solutions is that you need people to use it.
Yeah.
It's you can build it in collaboration with
Correct.
society, but how do you get people to use it? Because there are so many diseases.
Yeah.
We have so many digital health interventions and apps and the works, and it remains just another app.
Exactly.
So which app do I get? There's so much out there.
Exactly.
So how do we get people on these platforms? I've come to realization that it's easy to build.
Yeah.
It's the easiest part, but getting people to use it is a problem.
Yeah. So I think everything seems to be very separated. There is an app, okay, to just give a support for caregiver. There's an app to give a medication reminders. There's an app to give some kind of maybe training. So it is not integrated in a way. So that is why training of how to use those apps are very important, not only among caregivers, but also existing healthcare professionals. Because when we integrate with those digital health platforms with healthcare professionals to be part of the intervention, it could have a better solutions for the caregivers to reach to the needed people whenever they have.
I can already see an app which combines all your areas of expertise.
Yeah.
Right from diagnosis to linkage to a GP, a primary healthcare physician, to, diagnosis, medication, and then how do you get the support from a non-governmental organization? There's so much that we can do. Come on, Dinesh, we're counting on you to come up with this dementia super app. Just don't think about one part of the solution, but a holistic solution.
Yeah, a framework.
Prof Tan, any input on awareness?
Well, it's coming, right? And we now have people knowing that about dementia, but the reluctance then to seek help is huge because of the stigma and accessibility issues. So until we can link all those things, the awareness can only go so far. Because at the moment, every time we have a meeting, we get together, the answer is always increase awareness. But you haven't got anything downstream to catch them when they think they have dementia. So the screening that's happening in our primary care through the people are demotivated to do it. Because when they find that they detect it, they don't know where to send them. They know that the waiting list in our government clinics is 1 year. And the people running the clinics are demotivated because by the time they see the people a year later, there's nothing they can do. And there's lack of empowerment for these people to actually pick and choose who they want to see, to actually increase the accessibility, increase their capacity, because we are so slow in training new dementia experts. And we're going backwards. So previously, we were able to recruit 15 to 20 new trainees in geriatric medicine every year. The last intake has been less than 5 in the last 2 years. So it is very, very alarming. And many more, we didn't used to have that many specialists leaving the services. And many more are leaving the service, going to private practices. So there must be reasons why they left. But we can still use, there are still dementia experts sitting in our country. We can still make good use of their expertise. And that's in the government sector. But the private sector, and they go to the private sector, they can't practice proper geriatric medicine because the whole private sector services are not set up to deliver geriatric medicine. It's very, very siloed, very much just led by one single-handed doctor. And unless the whole system changes, we can't really move forward. And we don't have a choice to say, oh, it'll never change. You can't say that. It has to change. And we need more and more people to believe of the need for change and to participate in this. There are lots of factors that we need to look at. We just have to look at them.
Okay. And the other thing I think I need to ask is, you've spoken so much about diagnosis. We've looked at, okay, once we're diagnosed, great, we've diagnosed, but then what after, right? Prof. Tan, you say there's a new pharmacological option, which is very costly at the moment, which most people will not have access to in the near term. But what about non-pharmacological options? Jenny, I'm sure you deal with that. And I've read a lot about music therapy, physiotherapy. A lot of that is needed for people living with dementia. And that costs money as well, right? So what's been your experience?
Right. So in ADFM, we are doing that. So the non-pharmacological approach that we adopt at our community center, we get volunteers to help us to run different sorts of activities, music therapy, brain gym, art and craft, even a new kind of therapy, sound therapy. Yeah. So all these are free of charge, and they need to register with our staff managing that, and they can join in from Monday to Sunday from 2 to 4 p.m.
Okay.
It's overwhelming. Most of the time it's full because person with dementia will need to be accompanied by a caregiver. And this is at Taman Mega Rise Mall.
Okay.
Yeah.
How do we get in touch with you?
You can either walk into the center, register, or just call ADFM.
Okay.
They are oversubscribed. So because the problem is we can't scale it, right?
Yeah, because this is free.
Yeah.
Yeah.
And not sustainable.
Yeah.
If you think about it, not sustainable in the
Well,
longer term.
we are lucky because we get a free space to do this.
Okay.
Yeah.
It's maybe an option for some of us to come forward and start volunteering, perhaps. We need more people, more hands on deck, actually, when it comes to this. Let's talk about cost. Probably another doom and gloom area. But what have you seen in terms of cost, Jenny? Can people afford? How is there a plan in place between you and Prof. Tan? We have the dementia action plan. Does it address cost at all? Where are we?
It is very costly. Our health service is already paying for it, even though there's no ring fence money for it. So what's happening is a lot of people are being admitted to hospitals at a very advanced stage of dementia. The caregivers are at their wits' end. Sometimes they disappear. We can't find them. So there are a lot of older people sitting in our public hospitals, not with nowhere to go because there's no downstream long-term care system to help them. The families are at wits' end. They don't have any facility. They can't look after this older adult because they still have younger children to look after, and they have to keep their job. Otherwise, there's no one to put the food on the table. So the whole system is losing so much money and delivering very ineffective care. So we're actually saying to them now, if you reallocate your resources, front-ended, then you're actually going to save a lot of money. This is going to be cost saving if you can actually make our people living with dementia more independent. Because what happens with the family is as soon as they seem to be a little bit forgetful, they just take over. Right? I can no longer manage my finances. I just take over your finances instead of helping them manage it and activities of daily living. They can still do things. It's just that they might not remember whether they've put salt or not. So you need a way of actually indicating that the salt has been has been put in, just a monitoring to say, someone keeps the salt and then they'll put the salt and then take salt away or something like that. Or if there's a gas cooker, they forget to turn it off, change it to an induction cooker. So there are ways that you can still maintain their independence, but without the training, by the time we get the person, they are already disabled. So then the cost of care and the whole strain on the system is so much greater.
I think we often forgotten the indirect cost of dementia, the caregiving. The caregiving is the indirect cost that normally not even accounted in any economic, when we look at it economically.
Yeah. So in the next 10 to 20 years, what do you think dementia is going to look like in Malaysia if we don't do something now?
If we don't do anything now.
Yeah.
If we
So
don't
socially or economically or emotionally, how do you feel about that?
I think all the three areas we gonna be suffered. If I look at the social structure, we look at the care partner, caregiver, they will have more strain and then I would say that they are already overburdened, but they are just saying showing their faith, showing that they are strong and there's no problem at the surface. But it will affect the family structure, and then we are maybe more relying towards the paid carer, like institution, but we don't prepare that yet. Then, yeah.
So there's also an indirect cost of the impact on the family. So sandwich generation, for an example, they have children to look after or take care of. And those units sometimes break down because of these challenges, right? What about you, Dinesh, in the next 10 to 20 years?
I think it's going to be a very tough road for all of them if it's not going to be managed well. As a pharmacist, I think medication management is something super crucial, and as what all of y'all mentioned, one of the reason why the denial and stigma is because of how are they going to cope with medication once they're given. So they are super afraid if there's going to be side effects, if there's going to be what if this medication interacts with another medication. So this awareness seems to be very lacking among the caregivers, and because they do not communicate this to the GPs or even the doctors and the pharmacists, holistic framework and the channel is quite lacking among this the whole thing. So I think it is good to have this communication channel quite streamlined in a way to have home medication reviews, this which is very much I'm closely working upon, where having a medication management programs for pharmacists on how to look at managing medication for people with dementia, even at their homes and also nursing homes. This is what we can.
Okay. Jenny?
Right.
If there's one realistic change, perhaps, that you would like to achieve in the next 5 years to improve dementia care?
Right on the topic. Just last week, the government have actually invited NGO to sign an MOU, Rakan Kerajaan. And with that, we hope that we can create an impact. So each NGO have to come up with 3 projects to last for 5 years, how to improve the system. We are still thinking what we could do on that, on the 3 topics. So we'll keep you informed. But we definitely would like to see a change in that of sustainability as an NGO. What we could do to help, especially, regardless of whether a person is able or not able to afford. But as an NGO, we want everybody to come together to support that so we can care for the community.
Okay.
From the beginning until palliative.
Mopin, your message for all of us who, if we can try and prevent it, why not? And the fact that we have some hope now that there is a medication that can help.
Yeah, so medications only go so far because prevention is very, very vital. And a lot of the treatment actually involves chronic disease management. So pharmacies are very important. So what you see is as soon as the memory goes off, the chronic disease management goes off. and then the cognitive decline accelerates. So if we can actually manage chronic diseases well, even with people with cognitive impairment, that will help. And early diagnosis, people coming forward, accessibility. So we are actually looking at working with GP partners to actually decongest our memory clinic so that people can have timely access to early diagnosis, and that will hopefully arrest any further deterioration, if possible, even reverse the disease onset. So lots of things that can be done that are low-lying fruits that does not need to rely on that very expensive drug.
And we also hope that this almost perfect dementia action plan that we have will be implemented and prioritized for the sake of all Malaysians. Thank you all very much for joining us today. Professor Dr. Tan Maw Pin, Jenny Lim, Dinesh Sangarran Ramachandran, and Siti Maisarah Mattap on the topic of Beyond Forgetfulness, Rethinking Dementia Care in Malaysia and the World. This has been Future Conversations.
You were listening to Future Conversations, a podcast by Monash University, Malaysia. For more information, email mum.media@monash.edu.